Hello, my friends. It's Dr. Sharon with Clinic Reviews. Do you have trouble telling the difference between placenta previa and abruptio placenta? Am I the only one that forgets which one is which? Well, I'm going to teach you that today. Hopefully you'll remember it. You do need to know it for the NCLEX, so stay tuned. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe, in my opinion. Clinic Reviews can be found at clinicreviews.com. You can sign up for the on-demand NCLEX review. You can do our streaming, which is commercial free for all of our videos that you find here, plus others. And you can also sign up for our small group tutoring. That includes, it's a monthly price. You get 4 tutorings. One of them I do, 2 of them Mark does, one of them either Trevor Mueller does or Dr. Pete. All right. So one thing I have trouble with is telling the difference between abruptio placenta and placenta previa. So this is not going to be a real long video, but we are going to cover that. And it's the blue book. You can get the blue book at Amazon. Type in the blue book, Mark Klimek, and it'll come up. You can also get the app at clinicreviews.com. All right, let's do this. A nurse is caring for a pregnant woman at 34 weeks gestation who is diagnosed with abruptio placenta. Oh, sorry, I left the British spelling in here, placenta. Okay, there's no E on the end. I got rid of it on the next sentence. Let me start over. I got distracted. A nurse is caring for a pregnant woman at 34 weeks gestation who's diagnosed with abruptio placenta, which I find best describes abruptio placenta. So she's 34 weeks. She's not full term yet. 37 weeks is full term. All right. The placenta partially or completely covers the cervical os. The placenta prematurely separates from the uterine wall before delivery. The placenta fails to implant properly in the uterine wall. The placenta becomes infected and leads to chorioamnionitis. Well, I know C and D are not it. So it's either A or B because one of those is placenta previa and one of them is abruptio placenta. So abruptio placenta is when the uterine wall prematurely separates. The placenta prematurely separates from the uterine wall. There usually is some bleeding, but the big key thing is pain. This is painful, as opposed to abruptio placenta, where the placenta partially or completely covers the cervical os, basically covers the cervix. Okay. That is painless, but there's a lot of bleeding. So it's painless bleeding. Placenta previa, painless bleeding. Placenta previa, painless bleeding. Abruptio placenta, painful, very little bleeding. Some bleeding, but it's not the key thing they noticed. It's the pain that really gets them. Which of the following pregnant women is at highest risk for developing abruptio placenta? So abruptio placenta tends to occur later in pregnancy. There are risk factors for it. Age is a risk factor. Multigravida is a risk factor. Let's see. Drug use is also a risk factor. So those are the risk factors. So when you look at this, you're saying who has the most risk factors? Whenever you get a risk factor question, if you have more than one person who has risk factors, you pick the person who has the most risk factors. Okay. So what you just count, right? So 32-year-old woman with a history of preeclampsia. Well, 35 is sort of the age. Okay. 35 is sort of the age. So I'm not going to say 32. Preeclampsia is not a known risk factor. So I'm thinking no on A. 25-year-old woman, age, nope, not old enough. History of gestational diabetes, not a risk factor. 29-year-old woman, 29 is not old enough. Previous C-section, not a risk factor. However, multigravida is. So let's see. Previous C-section, C is a multigravida. It doesn't, if she had a previous C-section. History of preeclampsia doesn't tell me that she's a multigravida. B doesn't tell me she's a multigravida. So C, the age isn't old enough, but she has had a C-section in the past. So she must be a multigravida. So that's the only risk factor I found so far. 40-year-old, okay, there's age, history of smoking, and cocaine use. 3 risk factors really. Age, smoking, cocaine use, that person has the most risk factors. So that's the person I'm going to pick. So age over 35, drug any kind of drug, tobacco, cocaine, heroin, any kind of drug use, and then multigravida. Those are the key risk factors for abruptio placenta. A pregnant woman at 36 weeks gestation presents to the ED with vaginal bleeding, severe abdominal pain, and uterine tenderness. Which of the following conditions should the nurse suspect? So 36 weeks, she's late in pregnancy. She's in her third trimester. She's not completely full term yet. I have to work through this in my head. Like I could just go and answer it. Like I know what the answer is because I wrote the questions, right? But I have to work through this in my head. I want to show you how I think. I don't want to just answer the question. I want to show you how I think, because it's all about clinical reasoning, which is critical thinking. Okay. So we have a woman who's pregnant. She's not full term, but she's late in pregnancy. She has vaginal bleeding. It doesn't say excessive. Like, I don't know how much vaginal bleeding. If it was, she was like hemorrhaging out, I think it would tell me that. So she has some vaginal bleeding, but the pain is key, and uterine tenderness. So abdominal pain and tenderness. So that's a key thing. I told you abruptio placenta, the key thing is abdominal pain, right? It's painful. Placenta previa is painless with a lot of bleeding. Abruptio placenta is painful with less bleeding. Placenta previa, no, because there's pain. Abruptio placenta, yes, because there's pain. Preterm labor. It doesn't say she's having regular contractions. I'm not going to say preterm labor when it says that she's not having regular contractions. Y'all, the best indicator of preterm labor, of any labor, the best indicator that someone's gone into labor is regular contractions. So she's not having, don't say, well, she's having pain. No, they would have to tell you she's having regular contractions. Otherwise, I'm not saying she's in labor. Ectopic pregnancy. She wouldn't have gotten to 36 weeks with ectopic pregnancy. Okay. So abruptio placenta is the only answer here. And I hope you understand why I did not pick the answers I did not pick and how I thought through it. It's not that it's such a hard question. I mean, you can memorize the information, but you know what? It's hard to memorize everything. It's like not possible. So you have to be able to clinically reason through things. Which diagnostic test is most commonly used to confirm the presence of abruptio placenta? Well, it's when the placenta separates from the uterine wall. So what test visualizes the placenta and the uterine wall? Well, there's only one that really does that. I mean, I guess you could do an MRI, but that's rather ridiculous. It's a little bit of overkill to do that. The pelvic ultrasound is this kind of the standard. We're not going to go overkill and go MRI. So pelvic ultrasound is the correct answer. That's just, you just kind of know that one or you don't. Stress test has nothing to do with it. Amniocentesis has nothing to do with looking at the placenta. It has more to do with looking at DNA and some other things. And the MRI probably could, but that's not what we use. A woman at 38 weeks gestation presents with signs of abruptio placenta. What is the priority nursing action? All right. Y'all, you got to read this question the right way. She's 38 weeks gestation, which means she's full term, which means it's safe to deliver the baby. If she was 34 weeks gestation, I would have a different answer than I will at 38 weeks. You have to think like this. 38 weeks is full term. It's okay to have the baby. And she's abruptio placenta. Priority nursing action means if you can only do one thing, which one thing are you going to do? It doesn't say what is she going to do first. It says what's best. Best and priority are the same thing. So what's best here? You can only do one thing. Administer oxygen. I mean, I might administer oxygen. I can't totally cross it off. That seems like a good thing to do. Obtain a CBC? Probably not. It's not heavy bleeding unless they told me she was having heavy bleeding. I'm crossing B off. Prepare the patient for an immediate C-section. So what do they do when someone has abruptio placenta? A C-section. That's what we do. Would we do an immediate C-section if she was 34 weeks? Probably not. Now, I'm not saying it wouldn't be the answer here because the other answers maybe don't make any sense, but I'm just saying I would be hesitant to prepare her for an immediate C-section if she were 34 weeks. The key thing here is she's 38 weeks. We can deliver this baby, and the C-section is what we do when someone has a placenta previa or abruptio placenta. We got to do a C-section, insert an indwelling catheter. I mean, I might do that, but I'm only allowed to do one thing, y'all. I'm only allowed to do one thing. So would I apply oxygen? I probably would, just to be safe. Would I insert an indwelling catheter? Probably, if we're going to do a C-section, but I'm only allowed to do one thing. If I can only do one thing, what do I have to do? I have to prepare her for an immediate C-section. So remember, this is a priority or a best question, not a first question. During a prenatal visit, the nurse identifies which of the following is a modifiable risk factor for abruptio placenta. Advanced maternal age. Okay, that is a risk factor. Multiparity. That is a risk factor. Hypertension, I didn't say that before, but that makes sense. So that would be a risk factor. Tobacco use. So let's say all these are risk factors. And you go, I don't know which one's a risk factor. Well, let's say they all are. And in fact, they all are. So what is the difference between a modifiable and a non-modifiable risk factor? Y'all, this is a fundamental question. You should definitely expect to get an NCLEX question on modifiable versus non-modifiable risk factors. You have to know what the word means. Modifiable means it can be changed. It can be changed. So can you change maternal age? No. Can you change how many babies she's had? No. Now, here's the big question, and this is a question I've had for a long time. Is hypertension considered a modifiable risk factor? I would say I think of it as it is a modifiable risk factor, but which one is more modifiable? Which one's more, tobacco use or hypertension? If I have to pick one and I'm like, I'm not sure hypertension is modifiable, which one do we know for sure is modifiable? Y'all, we know for sure tobacco use is modifiable. You pick the answer you know is modifiable, not the one you're not sure about. And so people would say, well, and this is an argument I could even make. It's modifiable because we could give them medication, we could do lifestyle modifications. That's why I would argue that it's probably modifiable. But I don't know how the person who wrote the question, I wrote the question, but let's just say I don't know how the person who wrote the question is thinking of it. So I have to pick the one I know for sure. Nobody's going to argue about the fact that tobacco use is a modifiable risk factor. Everybody, 100% of the people would accept that tobacco use is a modifiable risk factor. I want you to hear what I'm saying right now. You pick, I've said this in so many videos, y'all. You're getting tired of hearing me say it. You pick the answer you know is right, not the answer you're not sure about. A nurse is assessing a pregnant woman with vaginal bleeding. Okay. Which of the following findings would help differentiate abruptio placenta from placenta previa? Oh, that's a good question. All right. They both have vaginal bleeding. I will say placenta previa has more vaginal bleeding, but there's another distinguishing factor. And what is it? Painless vaginal bleeding. No, that's placenta previa. Painless. Absence of fetal movement. No, both put risk for fetal demise. They're both risk factors for fetal demise. Uterine tenderness and pain. Yes, that's it. Painful. There's it. There it is. Abnormal fetal heart rate pattern. No, they both could have that. A is absolutely wrong. B, they both could have. D, they both could have. C is only abruptio placenta. My dog is down here, so if you see me doing something weird with my hands. Which of the following is a key component in the management of a patient with mild abruptio placenta at 34 weeks gestation? Mild abruptio placenta at 34 weeks gestation. So 34 weeks gestation, they are not full term, but abruptio placenta, y'all, is a big risk factor for fetal demise, even if it says mild abruptio placenta. If they had mild abruptio placenta at 38 weeks, y'all, I'd be getting them ready for a C-section, okay? But they are not full term. They're preterm. So I really don't want to immediately induce labor. I really don't want to do that. She's only 34 weeks. Hospitalization with close monitoring of maternal and fetal status. There you go. I really like that answer. Let's see if there's anything else I like. Administration of corticosteroids to enhance fetal lung maturity. Well, I could do that. In case we need to deliver preterm. So I could do that. Outpatient follow-up with no, I don't like D and I don't like A. So let me reread the question because I like C. That would be appropriate. Which of the following is a key component in the management of a patient with mild abruptio placenta? So a key component. Administration of corticosteroids at 34 weeks, you can do it, but I wouldn't say it's a key component. Whereas hospitalization with close monitoring and maternal fetal status, you got to do that. That's like key component, y'all. We have to do that. I suppose it could be a priority. You could maybe even say best. It's not quite a best question, but you never know how something's going to be worded, and it's not first. It's a key component. So I would answer it like a best question. Which one do you have to do? I would have to do B, because remember, abruptio placenta is a serious high risk indicator or high risk factor for fetal demise. We've got people who develop abruptio placenta, we've got to monitor them carefully. Which fetal complication is most likely to occur as a result of severe abruptio placenta? Which fetal complication? Fetal growth restriction, congenital anomalies, intrauterine fetal demise, or neonatal jaundice? Well, I just told you the answer in like the last two questions. Okay. So a complication is something you don't expect to happen. A symptom is something that always happens, right? So like a symptom of abruptio placenta is abdominal pain. That's a symptom. A complication is something that you're trying to prevent from happening. So you can have abruptio placenta without intrauterine fetal demise. You bring them in, you monitor them, you take them for an emergency C-section if there's indications that the baby's not doing well, right? So you can prevent that complication, but it is a serious risk. All right. Well, that's the end of it. And I hope that was helpful to you, short and sweet. I enjoy talking about that stuff. I'm a doula. I don't know if you don't know what a doula is. It's like a birth attendant, a birth assistant. So I just think labor and delivery is like the coolest thing ever. Both my kids were adopted. And so I never went through the labor and delivery process. So I got to go through it with my daughter. It was the most amazing thing I've ever seen. And it was just the coolest thing I've ever seen in my entire life. Those of you who've delivered a baby, y'all, you have my highest regard. It is just an amazing thing. Before I go, I just want to clarify something with you. You know, I teach these videos to help you pass NCLEX. It's not necessarily always the same when you're in clinical practice. Remember, clinical practice is all about specific situations, specific patients, specific labs, specific comorbidities, specific providers, whereas the NCLEX is more about general principles. So on the NCLEX, when they talk about abruptio placenta, they're going to talk about painful. There'll be some bleeding, but probably not a lot. There can be a lot of bleeding with abruptio placenta, depending on where the placenta separates from the uterine wall. But that's not what you're going to see on the NCLEX. Okay, so the norm on the NCLEX is going to be painful with bleeding, but not as much. Sometimes you'll have very little bleeding. Usually they'll say they have some bleeding, but the key thing is going to be the abdominal pain, whereas placenta previa is going to be painless, with a lot of bleeding every time, no exceptions. So I wish you all the best, and I'll see you later.